that the screen that yes, madam. Yes, perfect. We can start, madam, if you are ready.
Okay.
Thank you.
So today I will be, because some students had asked for this with the exam purpose, I have done a brief eye movement problems in brainstem disorders, mostly patients with demyelination and stroke. They present with a variety of eye movements, which is very useful in localizing. So those things are of relevance for exam purpose. So that way I have taken this. So this is one, I think Dr. Kishan Rao sent me this number. But so Dr. Dilip Kumar, I think it is meant for him. He had only asked. So with reference to eye movements, disorders in the brainstem can be of several. We have heard the basic 2 sessions before. So we have to recall all those principles of eye movement and then come to this. So the disorders in the brainstem with reference to eye movements can be of supranuclear nature, nuclear nature, or infranuclear nature. Anything. It can be supranuclear, nuclear, infranuclear. The characteristics of these involvements we have analyzed in the physiology of eye movement, which we have already dealt with. So supranuclear paralysis occurs when the structures which come from the fronto-mesencephalic or occipito-mesencephalic pathway, that is from the frontal lobe to the midbrain or occipital lobe to the midbrain, if these fibers are affected, you get supranuclear eye movement problem in patients with the brainstem involvement. What is the characteristics of these movements? They are conjugate, other than the Vergennes movement and the MLF movement. So supranuclear movements are all conjugate movements. They are not disconjugate like what we see in L11. They are conjugate movements, and they are except the exceptions being Vergennes and the MLF. As you know, Vergennes is convergence and divergence, so it's not conjugate. And MLF is supranuclear fibers to the medial rectus and lateral rectus on the opposite, so that cannot be not conjugate. So other than these two, all supranuclear eye movement problems are conjugate. Next is internuclear. The internuclear is when the mesencephalic nucleus medial, when the MLF or the medial longitudinal fasciculus, pretectum and reticular formation are involved. That is in between the nuclei. Various oculomotor nuclei are there. So those which connect these things. So MLF, pretectum and reticular formation. And they can develop internuclear diplopia, but eyes remain parallel in primary position. So how to differentiate? This is supranuclear. As we all know that diplopia is a feature of L11 and disconjugate eyes is a feature of L11. So how are you going to differentiate this? So exceptions for supranuclear producing diplopia is MLF and skew deviation, and so they can have diplopia. But when you have a straight forward in the primary position, eyes do not show squint. So that is the point to suspect that this may be supranuclear. So in the straight forward gaze, as you know, when there is a lateral rectus palsy, in the straight forward gaze, there will be a convergent squint on the affected side. If it is a medial rectus palsy, there will be a divergent squint on the affected side. But when there is a diplopia with disconjugate movement due to MLF involvement, in the straight forward gaze, there is no squint. This is a very important point. A nuclear and intranuclear are non-parallel in primary position. So the L11 is a non-parallel. L11 is non-parallel in primary position, whereas UMN is parallel in primary position, but during lateral movement, they can be disconjugate only with reference to Vergennes and MLF, and sometimes the pretectum and reticular formation. So let us see one by one. Supranuclear, the oculomotor subsystem, systems involved in the supranuclear are saccadic, pursuit, and Vergennes, and vestibular movements, which can be individually affected. So in the supranuclear, unlike the infranuclear, in the infranuclear, saccade, pursuit, Vergennes, vestibular, everything will be affected. But in supranuclear, saccade alone may be affected, pursuit alone may be affected, Vergennes alone may be affected, and vestibular movements alone may be affected. That is one key point. Second, they can be also be picked up in one plane only. So it need not be in all the planes, horizontal, vertical. So supranuclear movements need not manifest in all planes. And that may be manifest only in the horizontal plane or vertical plane like that. And voluntary reflex dissociation. Because supranuclear, the reflex movements are preserved like any other supranuclear. So voluntarily, when we tell the patient to move his saccade, he may move the eye, saccadic initiation may be defective, hypometric, hypermetric and all may be there. But reflexly, when he sees a danger or some object in front of him, quickly coming unanticipated target, he will develop a saccade. So that is voluntary reflex dissociation. So oculomotor supranuclear systems can be individually affected. It can be in one plane only, and there can be voluntary reflex dissociation. You tell the person to carry out a saccadic movement, he may not do, but reflexly he will do. If you are not aware of this point, we will think it is psychogenic, that when you are not observing, he is doing all these things. And vergence is used to do adduction in supranuclear, adduction failure in MLF. So vergence is used in supranuclear failure of adduction because the reflex movement is there. So that is used in MLF lesion. Next is internuclear. So supranuclear, the characteristics we have seen. Internucleus, in medial longitudinal fasciculus. That's a very important thing. It is always asked. There will be failure of adduction. Supranuclear failure of adduction on the side of pathology, and opposite eye will show nystagmus. So abducting eye nystagmus. Failure of adduction on in the ipsilateral side and nystagmus on the opposite side. That is one internuclear. As we have seen already, internuclear patients can have diplopia, but in the straightforward gaze, the ocular axis remains parallel. I am repeating the key points. Because diplopia, is it LMN or UMN? You become confused. So if it is supranuclear, diplopia is very uncommon. And if it is present, look at the straightforward gaze. There will be no deviation of the visual axis. Only during lateral movement, the gaze deviations become asymmetrical. In straightforward gaze, it remains parallel. Then the voluntary reflex dissociation, which I have told. Next is the PPR, parapontine reticular formation. Here, gaze paralysis to the side of lesion and eyes look away from the side of involvement. So, eyes look away. If it is a right PPR, the eyes will look to the left side. And when there is medial longitudinal fasciculus and PPR of involvement, these are all internuclear. We saw the supranuclear. Now we are dealing with the internuclear. When there is MLF and PPR of involvement, this produces failure of adduction on the ipsilateral eye due to MLF as well as abduction palsy due to PPRF. Adduction fails due to MLF on the same side. And if the right PPRF is involved, the eye will look to the left side. So there will be, when there is a combined involvement of PPRF and MLF, there will be failure of adduction on one eye, and there will be abduction failure due to PPRF involvement, and opposite eye adduction is lost again due to PPRF of the same side, causing 1.5 syndrome. So when there is a combined involvement of MLF and PPRF, it produces total loss of horizontal movement in one eye, and the opposite eye adduction failure. This is called 1.5 syndrome. And partial PPRF lesions produce gaze peritic nystagmus in partial lesions when moved in the line of palsy. So when there is paralysis to the right side, if there is a right PPRF involvement, the eye will look at the left side. So there will be a right gaze palsy. So when you try to move the eye towards the right side, there will be a gaze peritic nystagmus with the steadily slowing velocity. So when you move towards the right side, it produces a nystagmus which steadily slows in velocity. And partial vertical will, you can have partial vertical paralysis. It may be purely up or purely down gaze palsy. So these are the features in internuclear: MLF involvement, PPRF involvement, MLF plus PPRF, partial PPRF, and partial vertical up or down palsy. Then extraocular, then we are coming to the infranuclear. We saw the supranuclear, we saw the nuclear and the internuclear. Now we are coming to the element. With this we have dealt with in the primary classes. All the extraocular muscles are there. The principle I have told that you have to remember that recti act better in the abducted eye, oblique act better in the adducted eye, superior muscles intort. Superior muscles means superior oblique and superior rectus. Inferior muscles means inferior rectus and inferior oblique, they are extort. So superior muscles intort, inferior muscles extort, vertical recti, that is superior rectus and inferior rectus adduct, and vertical obliques abduct. So this is a brief mathematics of element. This we have dealt in detail. So this is an introduction to the brainstem and eye movement. So brainstem has extensive connection in the supranuclear level by the occipital mesencephalic and frontomesencephalic, then the internuclear level with MLF, PPRF and combinations, and nuclear level and element level. So all these can produce various syndromes. So we can see the brainstem, you see the superior colliculus, then the cerebral aqueduct, periaqueductal gray matter, then the oculomotor nucleus, then you see the medial longitudinal fasciculus just below the oculomotor nucleus. You see the medial longitudinal fasciculus, and you see the medial geniculate body. Then we see the medial spinal trigeminal lemniscus. Then you see the red nucleus, then the oculomotor nerve, and so these are the various structures, and this is substantia nigra, crus cerebri, and tectum. So various structures are there. This is the superior colliculus, tegmentum, reticular formation, substantia nigra, and aqueduct, periaqueduct gray, medial geniculate body, then the oculomotor nucleus, and we have the MLF, and we have got the sensory tract, and we have got the red nucleus. So this is a simple hand-drawn diagram, and we have 5 zones which have unique eye movement in brainstem involvement, midbrain involvement. The first zone is thalamo-mesencephalic junction. So thalamo-mesencephalic junction has got the superior colliculus, posterior commissure, tectum. So that is the thalamo-mesencephalic junction. Then we have got the median zone, we have got the paramedian zone, intermediate zone, and the lateral zone. So in the midbrain, 5 zones can be differentially involved, and these 5 zones can produce unique neural oculomotor signs. So that is thalamo-mesencephalic junction, median zone, paramedian zone, intermediate lateral zone, and lateral zone. And then, so that is in the anterior-posterior plane, and you can divide the midbrain into upper midbrain and the lower midbrain for purpose of eye movement. So that's localization. So 5 axial planes and 2 sagittal planes, superior and the inferior. So in the lower and upper and the lower midbrain, So here you have got as I told, thalamo-mesencephalic junction. They have some unique eye signs. This is supplied by the thalamo-subthalamic paramedian branches of the P1 segment of the PCA. As I told, these unique brainstem symptoms are commonly seen in brainstem strokes or demyelination. So thalamo-mesencephalic junction is supplied by the thalamo-subthalamic paramedian branches of the P1 segment of the posterior cerebral artery. And the next zone is the median zone. The median zone contains third nerve nucleus. This zone contains the tectum, posterior commissure, and mesencephalic reticular formation. The second zone, this contains the third nerve nucleus and the MLF. So accordingly, the eye signs will be different. And this is supplied by the basilar tip branches which come from the top of the basilar artery. Next zone contains the intraaxial third nerve. Here it is nuclear third nerve and MLF. Next is the intraaxial third nerve, that is fascicular third nerve. Then the intermediate lateral zone mainly contains only the MLF. And the lateral zone contains the brachium conjunctivum, that is the peduncle, which is supplied by the short circumferential branches. And fifth is the superior collicular or quadrigeminal branches of the superior cerebellar artery. So these are the various zones, and each one of them produce unique eye signs. So we will go to the thalamo-mesencephalic junctions. Usually it is cardiac emboli from that basilar tip. And mesencephalic reticular formation and posterior commissure. As I told, the most important structures which produce eye signs there are the mesencephalic reticular formation and posterior commissure, and they become affected therefore there is main involvement of the vertical gaze. Because that mesencephalic reticular formation as well as posterior commissure are concerned with the lid movement and the vertical gaze movement. So what are all the clinical syndromes in this thalamo-mesencephalic junction involvement? So you can have up-gaze palsy, pure up-gaze palsy you can have. So the eye will be not moving up. And you can have down-gaze palsy. So the eye will not move down. And you can have combined vertical gaze palsy. You can have up-gaze palsy, down-gaze palsy, and combined vertical gaze palsy due to bilateral rostral interstitial nucleus of the MLF and posterior commissure involvement. So you can have pure up-gaze palsy in the thalamo-mesencephalic junction. You can have the pure down-gaze palsy, or you can have a combined vertical gaze palsy due to bilateral or MLF and posterior commissure involvement. And you can have, why you get selective down-gaze palsy? It is due to bilateral mediocaudal or MLF. And selective up-gaze or combined vertical is unilateral mesencephalic reticular formation. So even unilateral mesencephalic reticular formation can produce combined vertical gaze palsy. This is important to remember. Mesencephalic reticular formation, even if the pathology is unilateral, it can produce combined vertical up and down gaze palsy or selective up gaze palsy. Selective down gaze palsy is RIMLF. Then up gaze with normal VOR. These up gaze palsy patients have normal vestibulo-ocular reflex. That is, when you do the doll's eye, the eyes move, as these fibers don't travel in the posterior commissure. So posterior commissure is the and mesencephalic reticular formation and RIMLF. We have seen that it is posterior commissure, mesencephalic reticular formation and RIMLF that get involved in this. But the vestibulo-ocular fibers are not traveling through this. Therefore, doll's eye movement will be normal. The VOR will be normal. And Collier sign, that is lid distractness. Due to posterior commissure involvement, the lid becomes retracted and produces tear. That is called Collier sign. So these are the thalamo-mesencephalic junction. Once when you go through it again, it will become very clear. Next group of symptoms, only rarely, we have seen that in the supranuclear, there can be dissociation of saccade, pursuit and VOR. Only rarely dissociation of saccade, pursuit and voluntary movements occur. Therefore, in vertical gaze palsy, up deviation, in down gaze palsy, or vice versa is rare. Because if they are dissociated, the available thing will move the eye. But generally, they are not dissociated. Because even though it can be dissociated, they are generally not dissociated. Therefore, when there is a vertical gaze palsy, up deviation in down palsy or down deviation in up palsy does not occur. And vestibular mechanisms, involvement through nucleus of Gajal is also responsible for this. The vestibular mechanisms, involvement through nucleus of Gajal. This we have discussed in the earlier session. The nucleus of Gajal is important for lower animals. We have seen that the lower animals have compound eyes. So major processing is not in the higher visual pathways. It is in the eyes itself. So when to measure the volume of a sugar solution, the housefly will tilt and rotate its eye. And that is carried out through the nucleus of Gajal. So because of this nucleus of Gajal's intactness and lack of dissociated involvement of all the supranuclear movements, when there is a down gaze palsy, also the eyes remain neutral. It doesn't move up. That's what we saw in the supranuclear lesions. In the neutral position, there is no squint. And you can have a skew deviation with the ipsilateral eye up. What is skew deviation? Skew deviation is a vertical disconjugation of the eye due to supranuclear cause. It is the MLF pathway that gets involved. So it is skew deviation is due to supranuclear involvement of vertical gaze. And in the it is not localizing by itself. But in association with other symptoms only you give a value. When there is a skew deviation in the midbrain, the affected eye remains up. So if the right eye is up, you can say that this patient's right midbrain is affected. So skew deviation with the ipsilateral eye. And seesaw nystagmus. Patients can have seesaw nystagmus, that is due to the horizontal gaze center and the nucleus of Gajal getting disconnected from the higher visual pathway. So this animal movement, the housefly movement, becomes released. So you get seesaw nystagmus. Then you can get palpebral nystagmus of pick. What is this palpebral nystagmus? You have got Pick's nystagmus and Papa's nystagmus. So lid keeps on showing the nystagmus movement. I had the videos, I think I put it in the previous talks. So palpebral nystagmus of Pick's is lid showing nystagmus movement. And there are two types. There is a lid nystagmus center in the midbrain. When that is involved, it produces a rhythmic movement of the lid, which has nothing to do with the eye movement. Whereas Papa's nystagmus happens in the lower brainstem, where you get a lid nystagmus synchronous with the eye movement. So this is a lid nystagmus, asynchronous with eye movement. That's called Pick's nystagmus due to involvement of the Pick center. Then there is a head tilt. So contralateral nucleus of the Gajal produces head tilt to the ipsilateral side, which looks like a fourth nerve palsy, what you get in fourth nerve palsy. Then retraction of the eyelid, that is a Collier sign, or blepharospasm, both can happen. You can get lid retraction or blepharospasm. So these are the thalamo-mesencephalic eye signs. Then what is this Pick type of lid nystagmus? Lid nystagmus not synchronous with eye nystagmus, and it is aggravated during convergence. So that is due to a Pick center in the midbrain. Then we have got horizontal eye changes. What are the horizontal eye changes? Horizontal eye movements show reduced contralateral circuits due to anterior cortico-pontine fibers. We saw that the occipito-mesencephalic and fronto-mesencephalic fibers are the supranuclear fibers which get involved. When there is a fronto-pontine fibers getting involved, horizontal eye movements show reduced contralateral circuits. So the eyes will have a preference to the ipsilateral side. Then you have got pseudo sixth nerve palsy. That is due to slow abduction during horizontal fixation due to increased convergence zone. So eyes converge because of increased convergence zone. So it will look like a bilateral sixth nerve palsy. So eyes converge due to increased convergence tone, not due to failure of lateral rectus. So it is called pseudo sixth nerve palsy. Convergence retraction nystagmus. So you can have convergence and retraction. So that kind of nystagmus can happen due to convergence and retraction taking place in a disinhibited way. Then spasm or paralysis of convergence or divergence. So it can be increased convergence or it can be paralysis of convergence. And wrong way eyes moving away from the side of pathology. Generally, we know that in the supranuclear pathway, eyes look at the lesion. So when there is a thalamo-mesencephalic junction disease, the eyes can look away from the side of lesion, and that is called wrong way eyes. Then you have pupillary changes. The pupil are usually 4 to 6 millimeter due to pan-autonomic involvement. And it can be 7 to 10 millimeter in parasympathetic involvement alone. If only parasympathetic involved, it can be 7 to 10 millimeter. And can be oval pupil, sometimes oval pupil, that is in the transient phase of progressive injury. So it can be 4 to 6 millimeter due to pan-autonomic. It can be large pupil due to parasympathetic. Oval pupil in the transient phase of progression to complete injury. And ectopic pupil or chorectopia due to segmental involvement of the pupil. And you can also get Argyll-Robertson pupil. Argyll-Robertson pupil is primarily constricted pupil with the preservation of good vision, accommodation reflex present, and light reflex absent. So that can also happen. Then, so these are the thalamo-mesencephalic eye movements. A group of signs and symptoms we have gone through. They are useful for localization. Then we come to the rest. We have saw the 5 zones. So the mesencephalic zone, it is purely mesencephalic. It's not thalamo-mesencephalic. Thalamo-mesencephalic is thalamus and midbrain junction. This is purely midbrain. Here again we have seen you can have prenuclear, nuclear, fascicular, oculomotor syndromes. So prenuclear will be gaze palsy, nuclear will be individual muscle palsy, and fascicular will be third nerve palsy. So all this can happen. Then that is you get pre-nuclear will be gaze palsy. You get nuclear individual. We know that there is a Warwick model for the third nerve. So when there is a nuclear third nerve, you can either get ptosis or you get bilateral ptosis. Either it is ptosis or bilateral ptosis, contralateral elevation defect, or individual muscle weakness can happen. Then you can have a fascicular third nerve palsy. That is the classical Weber syndrome, complete third nerve palsy on one side and contralateral hemiplegia. And you can have third nerve with ataxia, that is Claude-Nathanael syndrome. Then you got pseudo-Parinot syndrome. What is pseudo-Parinot syndrome? We know Parinot syndrome happens in pineal body tumor. When you have an ARP like people, you have upgaze palsy and you have a pineal body tumor. These are the classical triad of pseudo-Parinot syndrome. Pseudo-Parinot, you don't have a pineal tumor, you don't have a pupillary change, but bilateral elevation defect. This is because the superior rectus nucleus of right side goes to the opposite superior rectus muscle. And the opposite superior rectus muscle comes the ipsilateral superior rectus nucleus. So on, you know, the inferior oblique, which is an ipsilateral elevator, that is close to the superior rectus nucleus. This all we have seen in the primary eye movement controls. So due to involvement of the superior rectus nucleus which cross to either side, or due to the right superior rectus nucleus and the right inferior rectus nucleus, you get elevation defect on both sides without pupillary involvement or pineal tumor. And this is called pseudo-Parinot syndrome. Then you can have an internuclear ophthalmoplegia due to MLF is coming through this pathway only. Even though it is involved in thalamus-mesencephalic junction, it can be involved in the pure midbrain also. Then vertical 1.5 syndrome. That we have seen the mesencephalic reticular formation, you can get up and down. So it is up and down gaze in one eye and either up or down in the opposite eye. That is called vertical 1.5 syndrome. PPRF and MLF produce horizontal 1.5. Vertical 1.5 is complete gaze palsy of vertical plane in one eye and one plane in the opposite eye. And you can have bilateral mydriasis and bilateral ptosis. Due to pure internal ophthalmoplegia, nuclear levator superioris. Then down or upgaze palsy due to involvement of the fibers descending from the mesencephalic reticular formation to oculomotor nucleus. So these are the various things you get in the pure midbrain, not the thalamus-mesencephalic junction, pure midbrain. They are the mesencephalic syndromes. Then you can have pre-nuclear third nerve. That is what I said, contralateral elevation defect due to ipsilateral fibers to the opposite superior rectus muscle getting involved. And ipsilateral inferior oblique muscle results in ipsilateral elevation defect. Then vertical 1.5 syndrome occurs when there is an upgaze palsy with monoocular downgaze palsy. Then we have the other syndromes, the nuclear syndromes in the midbrain, that is ipsilateral complete third nerve with contralateral elevation defect, or you can have bilateral ptosis, you can have pseudo-Parinot syndrome, you can have isolated third nerve muscles, isolated muscles of the third nerve, and you can also have combined supranuclear and nuclear syndromes in the pure midbrain pathology. Then we come to the fascicular syndromes. You can have incomplete third nerve palsy with pupil sparing. People can be spared. And small pupil, when the descending sympathetic fibers are involved. Normally in a third nerve palsy, you expect a large pupil. We see the 4 Ds, diplopia, drooping of eyelid, divergent squint, and dilated pupil. But in a fascicular syndrome, which is intrinsic, sometimes people can be spared or the pupil can be small due to descending sympathetic involvement. And Weber's and contralateral ataxia producing Claude-Nathanael syndromes or fascicular syndromes. So that is midbrain. Now we are coming to the pons. Pons has got only 2 vascular zones. One is the paramedian zone and the lateral zone. Short paramedian branches supply the paramedian zone and the lateral zone supply the long paramedian branches. You can see the various structures. The 4th ventricle. This is the MLF. And this, you see, this is the 5th nerve. And you see the lateral lemniscus for the auditory pathway, and you have got the middle cerebellar peduncle and various tracts. So the zones are 2. In the midbrain, we saw there are 5 zones. Thalamo-mesencephalic junction 1 zone, and the mesencephalic junction 5 zones, and in the pons you have got 2 zones, paramedian zone and the lateral zone. Paramedian zone, again the MLF is coming from the thalamo-mesencephalic junction, it is going on descending. So you can have an internuclear ophthalmoplegia, that is ipsilateral restricted adduction with preserved convergence, because it is supranuclear involvement of the third node, the medial rectus and the lateral rectus. So you have preserved convergence and nystagmus of the abducting eye. And nystagmus can also be elicited by attempted elevation. Why the abducting eye is showing nystagmus? That is because you have told the patient to look to the right side. Let us imagine our patient has got a left INO. So left eye will not adduct, and so you have told the patient to look to the right side. So right eye has abducted. Left eye will not adduct because there is a left supranuclear failure of adduction. So because it is supranuclear failure, and first only I have told that reflex movements are preserved, the brain wisely recruits vergence to adduct eye. So but vergence is a disconjugate supranuclear movement. So when the left eye adducts, the right will also adduct, resulting in convergence. And then immediately the command is given to the right side, don't adduct, you have to move outside. So this adduction and abduction alternating results in the abducting eye nystagmus. And bilateral MLF produces bilateral adduction failure, and also vertical eye movement up can be lost due to involvement of the vestibular motor fibers, and convergence is preserved. So paramedian syndrome, you can have INO, you can have bilateral MLF also. Then paramedian, you get skew leviation with the ipsilateral eye up, like the midbrain. In pons also, you get a ipsilateral eye up. You get Millet-Guebler syndrome when there is a 6th nerve palsy and opposite brachiocrural hemiplegia. And when there is a PPRF can be involved, then the eyes look away from the side of the lesion and VOR is preserved. And VOR is lost if associated 6th nerve nucleus is also involved. Pure PPRF involvement, VOR is preserved. If the 6th nerve nucleus which is adjoining the PPRF is involved, then VOR will be lost. And partial lesions produce ipsilateral slow saccades and no paralysis. You can also get an associated 7th nerve palsy. Then paramedian horizontal 1.5 syndrome. That is PPRF and MLF involvement produces ipsilateral gaze palsy, and MLF produces adduction failure. So this is 1.5 syndrome. And bilateral lesions produce pan-gaze freezing. So bilateral lesion of the PPRF and MLF produce complete freezing of the gaze movements. And lid movement and vertical eye movements are preserved. This happens in locked-in syndromes. And convergence, divergence, synkinesis will result. So there will be a convergence retraction. Normally, there is no synkinesis between convergence and divergence. When there is a lesion, the pathological synkinesis became established, resulting in convergence and divergence nystagmus. And involuntary vergence movements on conjugate gaze attempts. So when you try to move to the right side or the left side, there can be either convergence or divergence, resulting in convergence, divergence, synkinesis. And ocular bobbing is intermittent downward jerk and slow return to midline. Intermittent quick downward movement and slow return to midline. So this is another movement we see in the pons paramedian. Then lateral pontine. Again, you can have horizontal 1.5. You can have 6th and 7th, lateral rectus and 7th nerve with contralateral hemiplegia. You can have ocular bobbing with a quick downward movement and slow return to midline. And you can have signs of vestibular involvement. You can have Horner syndrome. You can have contralateral hemiplegia and sensory involvement. Now we will go to the medulla. In the medulla also 2 zones. So in the midbrain, thalamo-mesencephalic junction is shared with the thalamus, then 5 zones. Pons, you have got 2 zones, and the medulla, you got 2 zones, medial medullary zone and the lateral medullary zone. The lateral medullary zone, you have got the vestibular nucleus, you have got the nucleus of the vagus, you have got the solitary tract, you have got the spinal tract and spinal tract of trigeminal, and then you have got the nucleus ambiguous, olivary nucleus, whereas the medial zone contains the pyramid, the 12th nerve nucleus, and the MLF. So the zones in the middle are lateral and medial. So we have the Wallenberg syndrome, very common. That's a lateral medullary syndrome. All of us know that Wallenberg syndrome or lateral medullary infarction. Here deviation of the eyes towards the side of lesion. It is, and there is ipsilateral saccades are hypermetric and contralateral saccades are hypometric. The eyes deviate towards the lesion like the frontal cortex because of the ipsilateral saccades becoming hypermetric and contralateral saccades becoming hypometric. And you can have spontaneous nystagmus. And you can get ocular tilt reaction or skew deviation with ipsilateral hypotropia. That's the ipsilateral eye down. That is ocular tilt reaction with the ipsilateral eye down. This is what happens in the nucleus of Gajal disconnection, where the animals have compound eyes. They use the eyes to measure the depth of the sugar solution by rotating the eyeball. So this kind of movements are suppressed in the adult human beings, and that becomes released and head tilt towards the side of lesion. And you have got, so that is skew deviation with the ipsilateral eye down, vertical or oblique diplopia due to skew deviation, crossed diplopia, that is worse during gaze to the unaffected side. Diplopia worsens when you are looking towards the normal side, and head tilt to the unaffected side also produces oscillopsia and a tilt of the visual field. That is because of the horizontal tilt center fibers in the utricle and the macule. So when you are sitting straight, you may feel that the roof is 30 degrees tilted and standing there. So tilt of the visual field. And you have got the Popper's type of lid nystagmus. That's a lid nystagmus which is synchronous with the nystagmus of the eye. And poor fixation causes blurred vision. They can have poor fixation. Because of that, they may complain of blurred vision. Then Popper's lid nystagmus is palpebral nystagmus, synchronous with the fast phase of the horizontal nystagmus. Then what is this lateral pulsion of Bari? Tonic conjugate deviation of the eye towards the affected side is seen due to ipsilateral bias of the saccade. So saccades are hypermetric towards the side of pathology. Because of that, there is deviation of the eye to the affected side. And this is called lateropulsion of Bari. There is a saccadic preference to the affected side due to failure of match between both sides saccade. So there is a hypermetric saccades to the same side, and this causes the lateropulsion of Bari and elicited by quickly opening a partially closed eye. And ipsilateral hypermetric and contralateral hypometric saccades seen are due to isolation of the vestibular nucleus from the nodulus due to the involvement of the rustiform body. So there is ipsilateral hypermetric and contralateral hypometric saccades that results in the ipsilateral deviation of the eye. That is called a lateral pulsion of Bari. Then in the medial medulla, you can get upbeat nystagmus. Then ipsilateral deviation of the eye called as the lateral pulsion of Bari that we saw. And this is due to isolation of the vestibular nucleus from the rustiform body. And medial medulla produce upbeat nystagmus due to extension of the pathology to the MLF. Then what are all the accurate localizing signs? So selective horizontal gaze palsy, paramedian pons. Vertical gaze palsy, upper midbrain. Pier rotary nystagmus, medulla. Lateral pulsion of Bari, medulla. So all other things are seen in multiple locations. These are very pure. So selective horizontal gaze palsy, paramedian pons. Vertical gaze palsy, upper midbrain. Pier rotary nystagmus, medulla. Lateral pulsion of Bari, again medulla. Now briefly cerebellum, we can, if anybody wants Yeah, it has got lot of eye movements. We will do in another session. So cerebellum horizontal pursuit becomes superimposed with microsaccades. That is called as cogwheel pursuit. And nystagmus is gaze evoked because of the leaky neural integrator. Those principles we have studied in the physiology session. So nystagmus becomes gaze evoked and it is larger amplitude to the side of disease. And upbeat nystagmus due to superior vermis involvement. And saccadic latropulsion or hypometria of the ipsilateral saccades. Unlike the hypermetria of the ipsilateral saccade in medulla, hypometria of the ipsilateral saccades and hypermetria of the contralateral opposite of Bari is seen in cerebellum. And combined features of brainstem and cerebellum are there due to shared vascular supply. As you know that the superior cerebral artery supplies the midbrain and the cerebellar connection. Anterior inferior cerebral artery supplies the pons and the cerebellar connection. Posterior inferior cerebral artery supplies the medulla and the cerebellar connection. Because of that, there is a sharing of the eye movements with the brainstem. And cerebellar eye signs can be dealt separately if needed. Thank you. So this is a exam-oriented preparation for eye science in brainstem. Any questions are there? We can ask. Shall we stop? Are there any questions?
Members, if you have any questions, you can directly ask madam. So many active members are there. It's a wonderful opportunity for you all to ask ma'am directly any kind of neurology related questions, maybe pertaining to this topic or anything in general. If you have any questions, please ask ma'am directly.
No, this because students asked,
Yes,
so I
madam.
have summarized in a precise way they can answer in the exam.
Yes, madam.
Midbrain, medulla, lateral,
Yes, madam.
vascular zones. You have to read once more and club it with anatomy and physiology, which we have done before. Then it will be very clear. Any doubt you can ask me. Usually, why there is dissociated nystagmus in MLF? That is one question people usually ask. It's a very simple one. You see, you tell the patient to move to the right side. So when he has to move to the right side, let us imagine left MLF. Failure, supranuclear failure of adduction is there on the left side. So when you tell the patient to move to the right side will move out. Left eye will not move, but it is supranuclear. So the frontal lobe will tell, use convergence and move the left eye inside. And we saw that vergence is a bilateral movement, disconjugate movement in the supranuclear pathway. So when the left eye moves inside, the right, instead of staying outside, will automatically move inside. Then the frontal correction goes to the right eye and tells you to remain outside. So this keep on alternating. So the right eye keeps moving out and in. That is the mechanism of dissociated nystagmus. This is usually asked in the exam. So unless somebody has told this specifically, the students will get them confused. Then the seesaw nystagmus, that's the nucleus of Gajal. Nucleus of Gajal is the center for the compound eye. The compound eye, the volumes of the object seen is measured by rotating the eyeball. But whereas human beings have simple eye, we don't have compound eye, we don't rotate our eyeballs. Our pathway also goes to Gajal, but Gajal is only a relay sender. Gajal sends it to the cortex. Cortex using three-dimensional percept. That is a parietal lobe, three-dimensional percept. It measures the volume, parieto-occipital. So the Gajal's nucleus is ineffective in humans. When there is a dorsal midbrain lesion, the nucleus of Gajal becomes disconnected from the cortex. So it becomes like the housefly. So one eye goes up and intort, other eye goes down and extorts. That is the seesaw movement. So this is due to loss of connection between the nucleus of Gajal, which is very active in lower animals with compound eyes. Humans with the simple eyes measure with the parieto-occipital strip. So we don't use the ocular tilt mechanism. So this becomes released. So the eye goes to tilt. Any other question? That boy from MMC, if he's there, you can ask. Who asked for this class? Otherwise, we will stop. Shall we stop?
Okay, madam. If any doubts are there, I'll forward it to you in message
Okay.
from YouTube.
Any
Thank you so
students
much.
exam going, if they want any specific topic also,
Okay,
they
madam.
can tell. Otherwise, I may do something about amygdala in the next class. I am thinking it's an emotional brain.
Okay, madam. Okay. Thank you, madam. Thank you so much. Thank you, students, for your active participation. Thank you.